Good afternoon. Thank you for being here. Thank you to Couchbase for giving us this opportunity to present our project. I'm from AEDES. AEDES is a public health consulting company, and we work mainly in developing countries. We have been working for about 30 years on the health information systems. There are 20 people in Brussels and then 60 to 70 people on the field in different projects working in developing countries. In AEDES, there is a small cell of only 2 people working on CERIS. CERIS is a hospital management information system that is for the small and medium hospitals in developing countries in challenging environments. So first, we will look at the current situation. So right now what is happening is that we are working only with paper. Here you have an example of a medical record for a patient. And most of the information actually is collected in registers. So those paper registers, you have about 25 of them that are spread through the hospital. And here for each line, it corresponds to 1 patient. So basically, you will enter the hospital, get to the admittance. They ask you who you are, they write your name, they write your address, your birth date, and then where you came, and they send you to the next place. And the next place may be the consultation at the doctor. We will ask you the same questions, and they'll fill in those forms, and perhaps you will want to have some lab exams done, so he sends you to the laboratory. The same thing again, you write your name, address, and everything, so data is repeated many times in there. And then on paper is also done all the monthly reports. So this is a requirement from the national government. You have to fill in those reports of about 20 pages, and you have to count every item that is happening in the hospital. So with that example of the laboratory, you have the lab exams. For a medium hospital, it's about 1,500 of them and 20 different types. So you basically take a register and you start to count on each line how many exams there were, and then you put it in the right cell in the report. The problem is that the report makes 20 pages, and there are hundreds of such queries to do. So this takes a lot of time. We have the same problem when we are in projects. Our experts are on the field. They have to get some information. For that, they have to dig up the registers from a few years ago, and they have to start to count lines. It's very complicated. There is another problem, it's archiving. So here is the archiving system for a hospital in a country, but it's not a bad example. I'm not taking an extreme case here. This is the information from 2012 to 2015. But when you have dozens and dozens of registers, after a while it's very difficult to dig through them. So you will just store them. And then you have the heat, humidity, rodents, and then just the sheer size of the information. So that's very complicated to get history. But information is a key component for health management, and for several reasons that are quite critical. The first one is healthcare of the patient. You definitely want their patient history. And then it's also very important for the hospital management. And for them, it's a question of seeing how many beds are busy in each department or the way they have to handle the human resources. And then another very important aspect is the national health information system. So those guys at the national level have to take the decisions that are necessary to ensure that everybody in the country has access to quality care at a decent price. And for that, they need the information about the whole country. But it depends on those monthly reports that you have to fill. So there is a very nice piece of software called DHIS2 in many of those countries. But you have that phenomenon of garbage in and garbage out. So you input data in that nice piece of software. And then since it's not a very trustable data, the output is difficult to use to take good decisions. You also, of course, have the information about epidemics. So I'm thinking here about cholera or Ebola. You want to have the info as soon as possible. So this is a perfect case where you would want an information system on an electronic way. And it does exist, mostly in large hospitals or hospitals that are private and have much money. But here we were talking about small and medium hospitals that have a lot of challenges. So we cannot just use the regular systems. And I'm going to go through the challenges that we can find. The first one, which is critical, is the limited financial resources. And cost is critical for the whole project at every level. Then you have power supply. And unstable power supply, that's when you already have power supply. Sometimes you don't have it. It's also more generally a question of the environment. You have the heat, you have humidity, you have dust. That's not easy to handle. And my experience in those hospitals is that when you go there, you check everything that can go down. And in most cases, it is going to break down if it can break down. So then you also have the poor internet connectivity. And this depends. Sometimes you have better connectivity, but it's expensive. Sometimes you have no connectivity at all. So cloud solutions are not an option. It's also difficult for remote controlling of the system. Then another challenge is the end user were unfamiliar with the ICT, and in particular with Windows. And then we have also the low availability of qualified technicians. We do have qualified technicians, but there are not many of them, and they are expensive. So for those hospitals of middle size, it's not an option to have a technician just in-house. We have also another difficulty is that the data is very diverse from one place to another. Each hospital wants something different, and then it changes from country to country and from year to year. So you have to adapt to that part too. Now, we'll see what solution we propose to handle all those challenges. And that's the series. Our project is, I took an example here. What we use is Android devices. This is not Louis Vuitton. But it's made in Congo, so we try to use. So we use Android devices that replace the registers. Already it's less expensive than using desktop computers. Of course, it can handle the power outages since there is a battery. And then it's much easier to use because it's not Windows, but it's a tactile system with Android. Many people have an Android device, or they have someone who has one and something like that. The way it presents itself is that you have the administrative data is on top, and then you have the different visits on the side. Here it's on your left. And for each visit, you have different events. The events, so admission and then medical consultation, going to a lab. So here you have 5 visits, and in a paper system, you would probably be lost already for the 3rd, 4th, and 5th one. That would be lost in that room I showed earlier. Here, doctors have it at the tip of the finger, literally, so they're pretty happy with that. When you look at a specific event, you will see the information. This is a false patient, of course, with the reason why he came there, diagnostics, and such information. Now, where Couchbase is used in that. So a basic design to represent the architecture of the system is that we have the server. The server is on your right. And there are 4 buckets there. User bucket is to see who can use the system. Metadata is the way we handle the very diverse data that is used in different hospitals. And then data is the information itself. We also have a cron job that runs NQL queries on a Node.js to produce the stats that are populated from the data. And then most of that information is synced with the mobile application on the client side. And that's through the sync gateway, of course. So now, how is that useful for us, for our use case? How does that answer to our challenges? It acts on several points. At the limited financial resources, the connectivity problem, the low availability of qualified technicians, and the large quantities and diverse data to collect. So an important aspect for us was that it was free and open source version. Of course, we don't have much money for that project in those hospitals. They cannot use the enterprise version, so they have to use the open source system. Extremely important was enabling the offline mode. So that's the part where you lose connectivity because the router goes down or the server goes down, and then you have your tablets. And in a previous iteration of the project, we tried to put a small web server that was in an intranet. And when it went down, all the tablets stopped working, and people went back to paper, and that was just it. So when we were able to tell them that we could continue to work, it made all the difference. And that was a selling point for this project. We have that reliable intranet setup. And that's the fact that we can put small intranet servers, and we don't run into problems with that. In our experience, you just leave them and they work. Very interesting for us is the light hardware too. So here it's very different from the other stories because they were talking about scaling up and we are scaling down. So the servers we are using are with the CPUs are i3, the mobile version. So that's probably less powerful than most notebooks in the room, and just 8 gigs of memory. And then it works on light hardware, but we can use horizontal scaling when we have to move up. So examples for that would be that through time there is more data from one hospital, or one hospital decides to work just in one department, see how it goes, and then add another department, and we can provide just another small server. They cost around 500 euros, so it's okay. Very important for us too was the data model was very good for the document-oriented NoSQL database, since we are going from paper documents to database with electronic documents. This does not answer to all our challenges. So the system is not just software, it's a bit more than that. And one of them is about to think how to charge the system and protect the tablets. And for that we work with the Polytechnic School of Brussels. So this is one of the examples. It's a case, it's modular. On the top part you have the server. Here is an example, it's a NUC of Intel. And then the router. And the middle part stores 10 tablets. And you can put them at night there, you lock them, they are charging. And then on the bottom, you have the batteries. Batteries are alimented by solar panels, the electricity from the grid when it's available between power outages, and then potentially a generator. Another problem is that we have no internet connectivity, so it's difficult to go and see how the system is working. So what we did again with the Polytechnic School of Brussels is design a system where the hospitals send daily SMS to a central server. So they check one SMS if things are working, and then when they detect a problem, they also send an SMS. Because while internet is difficult to obtain, the SMS system is available most everywhere. And those SMS are forwarded to the technicians who can then act and go on the site immediately or soon. It's important because it limits the number of visits you have to do to one of those hospitals. Some are very remote, others are in a place where the security is not great, so you don't want to run there all the time. We also have the possibility from Brussels to check if everything is all right. The next steps for us. First, the hospitals are requesting new features. So when we present the tablet and they start using them, they're very happy for what we saw. But they have very quickly they are thinking about everything else that they could do with it. And that's quite fun for us. One of the first things that they request is the billing module. And this is something our intern is working on. Another element is managing pharmacy. For now, the medication stock, often they check the first day of the month, they count what they have, and then they compare to what they have in the last day of the month, and they can see the difference. So, of course, they would like to see that directly through the tablet. And so, an interesting application is assistance for medical diagnostics. And then appointment scheduling. Appointment scheduling is the fact that when a mother, for example, comes to see the doctor, he wants to fit a new appointment in 1 month, and then have the ability to see if she did come or not, and then follow up. Because the other way to do it right now is to look up in those registers, which is not easy. And on our side, we also want to improve some other elements. And this is removing the single points of failure. So the first one would be on the server side, moving from single servers to clusters. And then another one would be to remove the routers, to have that other single point of failure that is gone. For that, we are looking at the peer-to-peer way to handle the system, and we know that Couchbase is working on that. And then we would also like to remove the server, if possible, with that peer-to-peer system. So another thing we're looking for is managing the deployment and the ease of maintenance, and that's putting Couchbase on Docker. So our technician can just spin off a cluster with a few lines. And then dimensioning the system more precisely. We don't have much time to do that right now, but we would like to look at the data that we collected and try to find the smallest possible server and the smallest possible solar panels to make it less costly for the hospitals. And finally, implementing new mechanisms. And for that, it's using the sync gateway, amongst other things, to separate documents between patients who are present in the hospital or who are not there, and data that is administrative or not. So we have quite a few challenges ahead of us, and it's very enthusiastic. The system right now is being implemented in the Democratic Republic of Congo. We have 4 sites in Kinshasa, and then soon in Burundi. I'm going there next month for 3 health centers. And after that, we're looking to put that in Togo, Benin, and Madagascar, mostly because that's where our clients are for AEDES. We are on projects there. So it looks like a few countries, but you have to realize that for the Democratic Republic of Congo, you have 9,000 health centers and 500 medium-sized hospitals. So if you do 1 per day, it's almost 30 years for a team to go install the system in every hospital, every small hospitals. So there is a lot of work. So that's it for me today. The contact information is there. Thank you for listening. We'll be available for questions. I have my colleagues there, Mathieu, Martin, and Erica. And then Vaes is welcome too. So thank you.